recording. All right, well, here's chapter 33, hematologic disorders, and it's a short chapter, but quite a lot of information on each slide, and we'll get right into the introduction. Hematology is the study of blood, the blood parts and the functions of the blood, and hematologic disorders, as the chapter name implies, talks about disorders of the blood or diseases of the blood. They include things like lymphomas, leukemias, myelomas, myeloproliferation disorders, like an increased number of cells. Coagulopathies are also included in hematologic disorders, and these are disorders of bleeding and disorders of coagulation, like your DIC, like your hemophilia. Hemolytic anemias, and that's destruction of the red cells, and hemolytic anemias would be, all the different types of anemias that are out there. Hemoglobinopathies are congenital abnormalities of the hemoglobin molecule or the rate of hemoglobin synthesis. Hemoglobinopathies include things like sickle cell. So the anatomy and physiology of the hematopoietic system. We'll talk about the functions and characteristics of blood. Blood is actually a connective tissue. It's categorized as a connective tissue. The cells, the blood cells, fragments of those cells, are suspended in plasma, and we know that blood supplies oxygen and nutrients to the cells. We also know that blood transports carbon dioxide and nitrogenous wastes from the tissues to the lungs and the kidneys for removal. Blood also carries hormones from endocrine glands to target tissues. Blood helps regulate your body temperature. Certainly when your warm blood is out of here in the periphery, if your vessels dilate some and the blood pours out here into the periphery, then you're able to dissipate heat through conduction, convection, radiation, and evaporation of sweat. And when your vessels constrict and that warm blood is shunted to the core, when it's cold outside, it helps maintain your body temperature. So blood helps regulate your body temperature. It helps regulate your pH through buffering components. So within blood are bicarbonate ions, and we know that from our acid-base days that hydrogen ions liberate, acids liberate hydrogen ions, and that pH is a representation of your hydrogen ion concentration. And the more hydrogen ions you have, the lower your pH is. And when you have a lot of hydrogen ions in your bloodstream, and your pH is lowered and you become acidic, it's the bicarbonate ions in your blood that help buffer that hydrogen, turn it into carbonic acid, which is a very weak acid that dissociates into water and CO2, and you exhale the CO2. So blood does help regulate your pH. Blood keeps your fluid, keeps your electrolytes in balance through salt and plasma proteins. Blood regulates the immune system through the carrying of white blood cells and antibodies, and blood forms clots through platelets and other clotting factors. Now, if we look at the composition of just what's in blood, we can see that blood is 55% plasma by volume, 45% of formed cellular fragments, which include red cells, white cells, those sort of things. Blood makes up about 8% of your total body weight. And the hematocrit is a relationship between the formed elements, well, the erythrocytes, or the red cells, in comparison to plasma. And you see there that, that's about 45%. So the hematocrit should be about 45% in relationship to plasma. Plasma is 92% water, 7% protein, and 1% minerals. Your formed elements, as you see there, include your leukocytes, your thrombocytes, your erythrocytes. Your red cells are called your erythrocytes, because erythro refers to red, cytes refers to cells, and then your white blood cells are called leukocytes, leuko referring to white, and again cytes referring to cells, so white cells, and thrombocytes refer to your platelets. The hematopoietic system and progenitor cells talk about the formation of blood and blood cells in the body. It starts with the stem cell, and stem cells come in a variety of types. As they mature, they turn into red blood cells, white blood cells, and platelets. This all originates within the bone marrow, and the lifespan of red cells and white cells it varies, and as a result, your body has to be able to renew or regenerate these cells. As the cells become more differentiated, they lose the ability to self-renew. Now, as far as the production of red cells, that's known as erythropoiesis. We know that tissues need oxygen for aerobic metabolism, and we know that they get that oxygen from red cells, particularly the hemoglobin molecule of the red cell. And when oxygen sensors within the kidneys detect minute changes in the oxygen amount of the tissue, in other words, when these oxygen sensors sense hypoxia, they allow the kidneys to release erythropoietin, and erythropoietin is the signal that causes the production of new red cells. Red cells are produced every 4 days, and without bone marrow we would not be able to produce red blood cells. Red blood cell structures. The red cell is round and bioconcave, and as a result of that shape, it's allowed some flexibility as it travels through the microvasculature. It can become long and narrow through tighter spots, and so it has some flexibility there when it gets together with other red cells. Because they're all in disc shape or round, they have a tendency to roll off each other, so they don't stick together. Red cells lack a nucleus and mitochondria, but they do carry hemoglobin in the red cell, and that's the part that oxygen attaches to. The red cell has a lifespan of about 100 to 200 days before the red cell is auto-digest by macrophages in the bloodstream. Hematocrit is the volume of packed red cells in relationship to the packed cell volume. It measures the volume of whole blood composed of red blood cells. It's spun in a centrifuge, and you saw a picture earlier of a test tube spun in a centrifuge where the red blood cells settle to the bottom and the plasma settles to the top, and the little bit of white in between might be the amount of fat or other elements found in the blood. The hematocrit normally is somewhere between 42 and 52% in males and 36 and 48% in females. the hematocrit represents the percentage of red cells. And if I have 42% of red cells as a male, my hemoglobin value would be 3 times that. The red cell production may be affected by altitude. At higher altitudes, you have a tendency to produce more red cells. In heavy smokers, there's a tendency to produce more red cells, and that's because of the chronic hypoxia in both high altitudes and in heavy smokers. The red blood cell count is the number of red blood cells per microliter of blood, and you can estimate the number of hemoglobin when you know your red cell count. Normally, the hemoglobin is 4.8 to 7.2 million in adult males. It's 4.6 to 6 million. Females, 4.2 to 5 million. In pregnancy, it's slightly lower than normal, and in children, it's slightly lower than normal as well. Hemoglobin is the molecule of the red blood cell that contains iron that carries oxygen. Total blood hemoglobin depends on the red blood cell count number. Each red blood cell can carry 4 hemoglobin molecules, and the hemoglobin in men should be somewhere between 13.8 and 18. The hemoglobin in women should be somewhere between 12.1 and 15.1, and in children 11 to 16. Pregnant women have a tendency to particularly in their third trimester, run lower hemoglobins because their blood volume increases 25%, but their red cell count doesn't. So as a result of pregnancy, even though they have more volume, particularly in their third trimester, they're actually anemic or slightly anemic because the red cell count doesn't increase with the volume. Low hemoglobins, examples would be anemias, bleeding, which is a form of anemia, leukemia, renal failure, iron poor blood, and iron and blood poor in vitamin B6 and B12 can lead to low hemoglobins. High hemoglobins are seen in patients who are chronically hypoxic, those with severe COPD, cor pulmonale, and cystic fibrosis. White blood cells, the normal myelopoiesis, which is the production of white cells. White blood cells fight infection and they aid in immunity, and again, because they are disc-shaped and can get long and narrow through tighter vasculature, they too move freely through the capillaries and into the tissues. White blood cells have a nucleus where red cells don't, and white cells lack hemoglobin. The average count of white cells is somewhere between 5,000 to 6,000. White cells are produced from stem cells, just like red blood cells are. White blood cells have a span of 13 to 20 day lifespan, and then they're destroyed in the lymphatic system. And we know that white cells are important for antibody production and also for heparin and histamine secretion. Different white cells are produced at different times to provide the body's host defense. Although all white cells share a common precursor cell, they do evolve, as we'll look at here, into different types of white cells that are present during different times of an infection or a reaction. With an acute infection, white blood cells release a colony-stimulating factor, which prompts bone marrow to increase white blood cell production. Leukocytosis refers to the doubling of white cells within hours during an acute infection, and leukopenia refers to an abnormal decrease in production of white cells. Now, the types of white cells include neutrophils, which make up about 70% of all your white cells, and you want to think of neutrophils as first responders. During the early stages of an infection, neutrophils will be found in higher counts because they're there as first responders fighting off the infection. Eosinophils make up about 4% of your white blood cell count, and they counteract histamine. So if you're having some sort of allergic reaction, then your eosinophils will be at a higher percentage. Basophils are the least numerous of white cells. They secrete histamine and heparin. And lymphocytes are cells that are abundant in the lymph tissue. There are T lymphocytes, which rid the body of bacteria and viruses through direct invasion. We call that cell-mediated immunity. And then B lymphocytes, which rid the body of bacteria and viruses through antibody production, and we call that humoral immunity. Excuse me. Platelets. Platelets are responsible for the formation of clots and coagulation. Platelets adhere to the vessel wall through this von Hillebrand factor, which allow platelets to adhere and stick together. So if that von Hillebrand factor is missing, as is the case in hemophilia, then platelets have a hard time sticking together. And normally your platelet count is somewhere between 150 and 400 million per milliliter of blood, and some factors that do influence the platelet count include exercise and racial origin, and racial origin is referring to certainly the presence of sickle cell anemia, which affects sickle cell anemia affects the production of red cells. So racial origin here is again referring to island Pacificers, African Americans, and their either overproduction of platelets or underproduction of platelets. During normal homeostasis, when there is an endothelial cell injury, bleeding starts, and blood vessels lined within the endothelium release the platelets, and the coagulation cascade occurs. And during the coagulation cascade, vessels constrict, platelets aggregate, and rich red fibrin weaves through the platelets to form a clot. And it's this von Willebrand factor that's needed for the adhesion of the platelets. As I had mentioned, the coagulation cascade occurs during an injury, which the vessels constrict, the platelets aggregate, the rich red fibrin weaves through the platelets, and a fibrin clot is formed. And once the bleeding has stopped, the clot itself eventually will be dissolved, and that's called fibrinolysis. And it occurs much after the wound was healed. Those clots that did form have to be dissolved. And of course, the medication that we may administer in patients having STEMI, ST segment elevated myocardial infarction from an occluded coronary artery, are called fibrinolytics because they help dissolve clots, much like the body's own system does. Blood typing and transfusions refers to the ABO and the RH blood groups. Agglutinogens refer to specific blood type antigens that are found on the red blood cell surface. And different blood types have different antigens on the red blood cells. And so we have this ABO blood type system as well as the presence or absence of the RH factor. And when we talk about transfusions, both the ABO and the RH must match. AB blood type is referred to, AB positive is referred to as the universal recipient, because an AB positive person could receive A blood, B blood, and O blood. O negative is the universal donor, because all patients could receive in an emergency O negative blood. So we'll look at some red blood cell disorders. Aplastic anemia is a decreased production of 1+ major hematopoietic lineages within the bone marrow, and as a result, red blood cells are not produced as frequently as they should be. And the end result, of course, is anemia or lack of red blood cells. Aplastic anemia is an inherited autosomal recessive pattern. We see it in patients with growth retardation and congenital skeletal defects. It has a heterogeneous phenotypic presentation. The cells themselves may have physical deformities and hematological abnormalities. The acute manifestations of aplastic anemia include just the anemia, but also neutropenia and thrombocytopenia. Neutropenia refers to a neutral amount, not too little, not too much, of the red cells, and thrombocytopenia is a condition where we lack red cells as a result of an increase in hemorrhage. Hemoglobinopathies occur as a result of a single amino acid substitution in one globin chain. A good example of a hemoglobinopathy would be sickle cell disease. Sickle cell is more common in African Americans and Mediterranean descents. The shape of the red cell is actually that of a half moon or a sickle. Because it is sickle shaped, it carries very little oxygen, but is part of the overall red blood cell count. So these patients are anemic as a result of not being able to carry oxygen because of their abnormally shaped red cell. And because they're abnormally shaped, they don't necessarily fit through those smaller vascular spaces. And when these cells aggregate or get together, they have a tendency to dam up, not necessarily form a clot, but to plug up and stop circulation. Physical findings of somebody in a sickle cell crisis where these red cells have obstructed blood flow through capillary beds include recurrent pain, chronic complications, anemia, the vaso-occlusion from the plugging up of the red cells, growth retardation, psychosocial problems, and they're more susceptible to infections. Hemolytic anemia is premature destruction of the red blood cells. It is hereditary. It's acquired glucose 6-phosphate dehydrogenase deficiency. As a result of this deficiency, Red cells are prematurely destroyed, and so they're anemic, and because they're anemic, they have increased fatigue, decreased exercise tolerance, congestive failure, and it's also an iron deficiency anemia. So iron poor blood um, exacerbates this condition. Methemoglobinemia is the oxidation of iron in hemoglobin from ferrous to ferric state. It causes globin chain mutations, results in an increased formation of methemoglobin. Methemoglobin doesn't carry oxygen either. And so in that particular situation, if somebody has hemoglobinemia or if somebody has methemoglobinemia, you might see that in a person who's cyanotic, but their PaO2 is normal. And remember the pulse oximetry, if you're relying on pulse oximetry to get your oxygen saturation, the pulse oximetry can't differentiate between normal hemoglobin and methemoglobin. Now there are new pulse oximeters out there that will tell you whether or not what you're looking at is hemoglobin, or what you're looking at is carbon monoxide, or what you're looking at is methemoglobin. Thrombocytopenia is when your platelet count is less than 150,000. It's a result of a decrease in platelet production and an increased destruction or sequestration of platelets. Causes of thrombocytopenia include infections. Certain drugs will decrease your platelet count. Radiotherapy, folate, vitamin B12 deficiency, marrow infiltration by a tumor or infection of your bone marrow, and hypothermia will cause thrombocytopenia as well. Hemophilia is a delayed clotting or a difficulty controlling hemorrhage. In patients with hemophilia, they often have reduced amounts of factor 8 and factor 9, and may have some genetic mutations of a portion of the X chromosome. It occurs in 1 in 1,000 births, and there are two types of hemophilia, hemophilia A and hemophilia B. DIC, which is disseminating intravascular coagulation, is a coagulation cascade that is triggered abnormally, and so it's considered a systemic thrombohemorrhagic disorder. You've got intravascular fibrin production, procoagulants, and platelet consumption, and when you have tissue damage with DIC, it leads to blood clot formation, and DIC is excessive clotting. The excessive clotting utilizes all your platelets, so you end up with actually uncontrollable hemorrhage as a result of DIC, because DIC is the abnormal coagulation cascade, an abnormal amount and use of your platelets, and your platelet count becomes very, very low, and then you hemorrhage easier in other parts of the body. And it's kind of weird, but the treatment for DIC is heparin to prevent those platelets from coagulating, to prevent those abnormal clots from occurring and using up all your platelets. Because at some point, once you use up your platelets, as I had mentioned, you don't have the ability to clot at all, and people with DIC just begin to hemorrhage out of all kinds of places. Causes of DIC include burns, major trauma, a dead fetus, intrauterine, placental abruption, placental previa, cancer, sepsis, and transfusion reactions. Acute leukemia is the result of immature hematopoietic progenitor cells. These progenitor cells rapidly multiply. They displace the normal elements within marrow and peripheral blood. It is fatal if untreated. It's also results in life-threatening elevations of uric acid, potassium, and phosphate in tumor lysis syndrome. Leukemia refers to white cells in the blood, and somebody with acute leukemia, the fatality comes from the fact that your white count is so low that you can get even a simple infection could be life-threatening because of your suppressed immune system. Hodgkin's lymphoma. Hodgkin's lymphoma is identified by the presence of the Reed-Steinberg cell. Hodgkin's lymphoma peaks in the second and third decades of life, and again in the sixth and seventh decades. It presents as fever, night sweats, weight loss, itchy skin. There'll be some sort of lymph node involvement, and the treatment for Hodgkin's lymphoma is a bone marrow transplant. Non-Hodgkin's lymphoma is derived from B cells. Those with non-Hodgkin's lymphoma develop swollen lymph glands, which is what adenopathy is. Swollen lymph glands, an abdominal mass, is classified by the morphology, the presence of the B cells. It's an immunophenotype. It has definitely genetic features and clinical characteristics is how it's classified. Indolent lymphomas is what non-Hodgkin's is. It says that chemotherapy can cure non-Hodgkin's lymphoma, but it's considered an indolent lymphoma. An indolent lymphoma just means that it is non-curable. It's not cancer, but it's cancer-like. In other words, these B-cell involvement is so slow and gradual that it is difficult to kill it all. Non-Hodgkin's lymphoma is also known as lymphoblastic lymphoma, and we said it was derived from the B cells. Multiple myelomas are plasma cell dyscrasias. You lose the ability to respond to signals from the immune cells. They divide and form abnormal proteins, and these abnormal proteins damage bone, bone marrow, and other organs. And the rapid repeated plasma cell production interferes with normal blood cell production. And then the plasma cells cause a lytic lesions in the skeletal and soft tissue, which lead to these masses. So when we look at hematologic emergencies, as far as your history and physical exam, we're not going to have you know, a lab with us, so we're not going to be able to get things like low red cell counts, high red cell counts, low white counts, high white counts, which white cells are present. We're not going to be able to see the B lymphocytes, T lymphocytes, and all those things that you know, they can see at the hospital. So if the patient isn't aware of their hemolytic abnormality, all we may know is that they're sick. And so we'll do our normal assessment like we always do, look for life threats, and manage our airway, our breathing, our circulation. assess the area of the body where the primary complaint is, inquire about pertinent system reviews, get a good past medical history using your sample, get an idea of what sort of medications they're taking, and whether or not they're using any illicit drugs, whether or not they have any allergies, whether or not they have any family history. That's all gotten in the sample. Management is to stabilize the hemodynamics. In other words, if they're hypoxic, correct the hypoxia, those sort of things. Secure the ABCs, assist ventilations when necessary, supply high flow oxygen. In some of these situations, the patient may require endotracheal intubation. If you suspect that the patient is in shock as a result of any of these conditions, and you can't find it anywhere, you have to suspect some internal blood loss, large bore IVs, but not necessarily fluid. We've talked about fluid management before for the patient with suspected internal hemorrhage or internal blood loss, and as long as the pressure is above 90, it's okay to establish 2 large bore IVs, but not necessarily run in lots of fluid. Like with sickle cell, the patient's going to be in extreme pain, and as long as the vital signs are able to support the use of an analgesic, then it's okay to go ahead and give them some pain medication and then transport to the hospital where they can determine what's going on. The epidemiology of hematologic disorders, they're going to present with hypoxia. They're going to present like an acute infection, anemia. And again, for us, anemia is very difficult to determine in the field. They might be cyanotic, which might be a good indication of anemia. Anemia is an abnormal amount of red cells. So pulse oximetry is going to be a little misleading, because a pulse oximetry tells you the red cells that you have are saturated with A gas. It doesn't tell you how many red cells you have. So a person could be really anemic and have a great pulse ox reading. If 98% of the hemoglobin you have is saturated with oxygen, you might think that's really good. But if your red cell count is half of normal, you're actually quite anemic, even though your pulse oximetry is good. Manage the ABCs, establish an IV, see if there's any sort of reversible cause in patients with altered mental status, like low blood sugar, hypoxia, hypercarbia, hypothermia. When you've got a person with a hematologic disorder and you see external hemorrhage, you're going to control that the way that you control all hemorrhage with direct pressure. We don't elevate extremities anymore, but direct pressure and potential tourniquet if direct pressure doesn't work. Or if you have an area that you can't put a tourniquet on, certainly packing the wound with a hemostatic agent and then direct fingertip pressure again. For sickle cell disease, as I mentioned earlier, they're in a lot of pain, they're anemic, so giving them oxygen, giving them analgesics for their pain, and just a normal saline IV at TKO. Hopefully the patient and the family has been educated about their hematologic disorder if they know that. So reassurance and comfort is something that certainly we need to provide to the patient and family. Avoid head trauma because intracranial hemorrhage is more likely in patients with hematologic disorders, particularly hemophilia. We had a a set of boys from one family. Both had hemophilia, and they lacked that Van Willebrand's factor, and the parents did not want to baby or coddle the boys and let them play in any sport they wanted to. And when they were out for football, they would, let us know that, our children have hemophilia, and should they suffer an injury and be bleeding, you won't stop the bleeding without this Hildebrand factor. And they had it and would bring it to the hospital so it could be administered to their children. All right. With that, that ends our discussion on hematologic disorders. Again, they happen to be, a wide variety of different anemias and different coagulopathies and those sort of things. It's difficult for us to diagnose that in the field. What we see is the patient who is short of breath. What we see is the patient who's doubled over in pain. What we see is the patient that has internal hemorrhage, and we may not know why because we just don't have access to that information, especially if they don't know they have this and they've not yet been diagnosed with it. So we have to be supportive, ABCs, IVO2 monitor, analgesics for pain, control external hemorrhages, we've always been taught, and get the patient to the hospital where they can provide the diagnostics necessary to figure out what's going on. So I'm going to end the discussion now, and I'll talk to you soon about environmental disorders.